exciting field and putting it all in perspective. Our last academic speaker is Dr. Brar. Savtaj Brar is actually a new recruit here at Sinai. He's a surgical oncologist or a cancer surgeon with a specific interest in gastric or stomach cancer. I'm sure many of you are quite well educated Lynch syndrome patients, family members, or just those interested in the field of cancer genetics. And even though the syndrome was initially called HNPCC, which is hereditary non-polyposis colon cancer, and that's the way it was identified in the early 90s. And before that, when Henry Lynch was following a lot of families, the colon cancer kind of dominated these families. And that's how the genes were discovered. But of course, these genes, as you've heard, are actually coding for proteins that are in the nucleus of all of our cells. And any cell that divides, it's at risk of errors, and then cancer can develop. So stomach cancer, endometrial cancer, and others are predominantly featured in some families especially. So the name was changed to get rid of the HNPCC so that clinicians and family members wouldn't get confused and just be looking for colon cancer. And stomach cancer is one of the unique features of Lynch syndrome, and Sav is one of our experts, so we're happy to hear about stomach cancer.
Thank you very much. I just wanted to thank Melissa and the organizers for the ability to speak. Most of my friends know that I like to talk a lot, but I do think you, the patients and family members, really make our jobs worthwhile. You remind us of the meaning of the work that we do, and these types of opportunities are very helpful to remind us of why we wake up every morning and try to solve these complex problems. I was asked by Melissa to speak about stomach cancer and the history of Lynch, and it was a good segue from Yuri about surveillance, and a very good segue by Steve. I'm going to basically speak about the risk of stomach cancer in Lynch syndrome. I'm going to discuss risk factors and outline the screening recommendations, and many of you probably know the recommendations better than I have because you've looked over them over and over again and worried about this stuff and worried about your families and are probably better experts than me, but I'll give it a shot. And the take-home message that Melissa really wanted me to hammer home is not to leave this talk and beg your doctors to get gastroscopy. And Dr. Tabori talks about fake news and good news. Well, in stomach cancer and Lynch, there is neither. There is no clear evidence to support surveillance for stomach cancer and Lynch syndrome in Western Europe and North America. That doesn't mean that there isn't benefit, we just don't have the evidence. And it's a very complicated reason, and it's a bit different than the other cancers in Lynch. One of the things that you should know is that stomach cancer is actually very, very common. It is one of the most common cancers worldwide. The highest incidence countries are in East Asia, but Canada is actually a very low incidence country. The graph I usually use to describe this is very hard to read, but 3,500 Canadians will be diagnosed with gastric cancer this year. About a quarter to a third of all stomach cancers in the world will be diagnosed in China. This map helps us see that a little bit easier. So Canada, you know where it is light, so there isn't that much stomach cancer. The countries that have a lot of stomach cancer are in East Asia, China, Japan, and South Korea. And I spent 2 months of my training in Japan to learn more about stomach cancer because it is a higher incidence gastric cancer area, and that's how I get roped into these talks. I spent 2 months in Tokyo, and all of a sudden I'm here with you guys talking about stomach cancer. So stomach cancer is rare in Canada, but there is an increased risk in Lynch. You guys know that colorectal cancer and endometrial cancer are the most common in Lynch syndrome, but there are increased risk of lots of other cancers, and stomach is one of the classic ones that are on these lists. And in fact, Lynch was described in the 60s by Henry Lynch. He described a few families. I'm not a geneticist, I don't have as many letters after my name, but when you see a patient that asks you, then you ask a question about whether or not they need surveillance, you start doing some investigating. And I'm a nerd and I'm on my phone all the time and I'm looking up stuff all the time. And interestingly, Lynch wasn't the first person to describe a Lynch syndrome family. 50 years ago, Lynch described Lynch syndrome in 3 families. 50 years before him, Alfred Warthen at University of Michigan described a family. They called it Family G. And they were called Family G because they came from Germany. And it was a famous story of the seamstress who told him, oh, I know I'm going to get cancer. That seamstress is in this top row. And she ended up getting endometrial cancer. And she knew this because she knew a bunch of her siblings had cancer. And he used this family to describe the preponderance of cancer that's probably related to some factor that they didn't know existed back then. This is 1913, right? This is before DNA, this is before genes. But they knew that there was something going on. And if you look at this top row, there's a couple of uterine cancers and a couple of stomach cancers. And what's interesting is in 1913, stomach cancer was actually a big part of this syndrome that we didn't know existed and we didn't have a name for, and it wasn't another 50 years before we called it Lynch. And what's interesting is that people tracked down the descendants of Family G. They had a family reunion in the Midwest of the United States, and they got hundreds of members of the family that had lived on, and they found that with each successive generation, it appeared that stomach cancer was getting less and less common. So the number that is thrown up, and the not fake news that Yuri put up said 12 to 17%, and in 2017 that probably is fake news. It's probably more around 7 to 8%, but there's a huge range, and what we think is influencing this is that the first hit and second hit. So we know that if you smoke, you have a higher risk of getting cancer. And in stomach cancer, there's a bacteria called H. pylori that was quite common in the 1920s, and about half the world still has today, but probably influenced how many people got stomach cancer. Other things, and we'll talk about this later, but the countries that have 12, 13% are countries like Korea. So stomach cancer was more predominant in Lynch 100 years ago because there's way more stomach cancer in North America 100 years ago. As the rates of stomach cancer in our countries have gone down, and they have for the last 100 years, the rates of the rates of stomach cancer within Lynch have gone down. So that's why this number is hard to pin down. That's why it was hard to get clear evidence to inform our decision making about surveillance in stomach cancer. So the number that, and I was up till late last night trying to find the best number for you guys, and probably the most up-to-date numbers are about 7 to 8% in families in Western Europe and the US will develop stomach cancer by the age of 75. And that is compared to the risk of less than 1% in the average Canadian. And in a high-risk country like Japan, that's about 10%. So you get a sense that even though it's much higher than Canada, it isn't as high as countries like Korea and Japan where they have population screening for stomach cancer. This is a graph, and it shows one of the peculiarities of stomach cancer, and in Canada this is true of the general population. More people will get stomach cancer that are male than female. And in Lynch families, the rate of stomach cancer appears to be higher in males than females. And you'll notice one thing here that's interesting as well, is that the age with which people are getting cancers is a little bit later than the colorectal cancers. And which also makes it hard to come up with an accurate estimate. Because you get H. pylori when you're very young, you live with it your whole life. Only about 1 to 3% of people with H. pylori will develop stomach cancer. So if you get in your 80s, people who are 20 now have a different risk of stomach cancer than the people who are 80. So people who are young and diagnosed with with Lynch syndrome now will not have this risk of stomach cancer. And so as time moves on, this number is going to change. So it might actually go from 12 to 19%, which they thought 20 years ago, to 7 to 8%, which they think now. It might be lower within this generation. It probably is lower within this generation. This is a combined Dutch and German, showing again that males are more likely to get stomach cancer than females in Lynch families, which is, in the German, so this is the same data as the Dutch graph I showed you. Add some German patients, and the rate is much, much higher. And what's interesting is people point to Korea as a high-risk country where 12% of Lynch families will develop stomach cancer. In Europe, Finland has about 12% according to their database, but it doesn't have a high risk of stomach cancer in the general population. It has about the same risk as the Netherlands. So it's hard to know exactly why these numbers are in such different ranges. And another thing that you may read about if you're a nerd like me is that the various genes seem to have a differential risk for stomach cancer. We know this is true for the types of cancers that each gene predisposes to, but it appears in most studies that the MSH2, the risk of stomach cancer in MSH2 is a bit higher than MLH1, and in some studies that there was no stomach cancers in any patients who had predominantly MSH6 mutations. We know that's not zero. We know in this group it was zero, but we know from other studies it's not zero. Another question that you asked is, once you've had one cancer, what is the risk of getting another cancer? And there was a study that Dr. Gallagher was a part of. He was a part of a lot of studies. And we looked at, after you've had stomach cancer, what's the risk of developing another cancer? And the risk of getting stomach cancer after a diagnosis of colorectal cancer was only about 1%, which is, about what the population risk would be. So it's very, very complicated, as you can tell, to figure out what is the true number. So what do we know about gastric cancer in Lynch syndrome? We know that most of the gastric cancers are intestinal types. So there's two main types, intestinal and diffuse. And the intestinal ones tend to be a bit easier to treat, a bit easier to do surgery for, and tend to do a little bit better. And we know that the intestinal types, when they actually have looked at it in Lynch families, appear to be a higher rate. So in a normal population, about 60% of people will have intestinal type, or 65, and we think about 75 to 80% will have intestinal type in Lynch. As I said before, it appears that MSH2 is a higher risk than the other gene defects, though it is debated and the numbers are small. And one important thing is, and the graphs did show that, is despite what you've read about when to get your stomachs checked or if you should get your stomachs checked, the risk before age 50 is quite low. So there's very, very few people with Lynch in the modern era that will get stomach cancer before the age of 50. But it's higher than the general population. In the general population, that risk is even lower. So that if you compare those two groups, it's a much higher risk to get stomach cancer below the age of 50. But for each individual or each family, that risk is actually quite low. And what's interesting is one of the things that we often say is, well, you probably don't have to worry about a high risk of stomach cancer in your family, stomach cancer in the Lynch family if there hasn't been stomach cancers already. And there's a debate about this. It may not actually cluster in families, and so we don't have an answer for that. So what does cause gastric cancer? As I said before, Lynch probably increases your risk of gastric cancer above and beyond the baseline risk of the population. So our population's risk has gone down, so the risk of getting stomach cancer in Lynch has gone down. But what increases your risk of gastric cancer? And this is important because this helps us inform the decision of who should be followed, who have been diagnosed with Lynch mutation to rule out stomach cancer. H. pylori is the highest risk factor for stomach cancer worldwide. About 50% of people worldwide are infected with H. pylori. Only 1 to 3% of those people will ever develop stomach cancer, and that's probably in North America, probably lower, like around the 1% mark. There's other things, other changes in the lining of the stomach that can put people at risk of stomach cancer, and these are the type of things that I think is the reason why it's important to speak to someone like myself who thinks and talks about stomach cancer a lot, because these other ones aren't as well understood and may inform our decision to perform an endoscopy or to perform follow-up endoscopy. So one thing is called atrophic gastritis, and another thing is called intestinal metaplasia. Metaplasia is basically the cells have changed. So it's, instead of having stomach cancer-looking cells in the stomach, you have intestinal-looking cells in the stomach. And normally, that's not a high risk for stomach cancer, but there are some variations, and there are some limitations to normal endoscopy that don't allow us to identify these properly. We know that family history in general, even though we're not sure anymore that clustering in families of Lynch leads to stomach cancer. We know if you have a first-degree relative with stomach cancer, your risk is higher than if you didn't. So that risk is still quite low in the general population, and probably still quite low in Lynch syndrome families, but we do know it's a risk factor. And then diet. So this is the one that's kind of complicated. So the evidence for these things aren't as good as the other column, but we do think that salty and salted foods is at a risk. And this is where sort of history sort of informs our science a little bit. So 100 years ago, there wasn't that much refrigeration, so how did you keep food? You filled it with salt. And we think the areas of the world where refrigeration came quickly, people got stomach cancer less. And it's because the food was much, much less salty. And it sort of makes up for the difference between the places where H. pylori rates have gone down, but stomach cancer has still been prevalent. Smoked, cured, or processed meat. I'm a vegetarian, so I'm not too worried about this. And then we think low intake of fruits and vegetables predisposed to stomach cancer. These are to scare you. These are all risks. They don't mean if you've had processed meat, you're going to get stomach cancer. But we think in the general population, a country like Japan probably has a bit more stomach cancer than a country that has the same H. pylori rate, somewhat because of the genetics, but also because of their diet. And we know that because when Japanese Americans grew up in Hawaii or in California, their risk of stomach cancer was between an American and a Japanese person. So we know that diet it does play a role, but obviously is not the be-all and end-all. So again, H. pylori is the most important risk. So I said worldwide the prevalence is about 50%. It's much, much lower in North America and Western Europe, but when you actually look at the number, it's not that much lower, so about a quarter of us still have it. And who is at risk? Non-white, people born outside of Canada, and people especially who immigrated before the age of 20. You get inoculated with H. pylori when you're in your infancy, and you carry it with you throughout life. The vast majority of people who have H. pylori will never have a problem. We know about 1 to 3% of people will, and we know that if you get rid of the H. pylori, which we can do with treatment that takes about 2 weeks, that your risk of stomach cancer goes down. So when we talk about prevention, when we talk about dealing with the cancer before it happens, this is one of the things that we think we can deal with. And in some of the guidelines, they talk about identifying H. pylori and eradicating it as a recommendation for patients with Lynch syndrome. So again, family history, stomach cancer increases the risk threefold in the general population. And as we said, we're not really sure whether or not family clustering does occur in Lynch, but it's at least a surrogate that we can look at. So what are the guidelines? So I said to you, my second slide was that we have no clear evidence that surveillance for stomach cancer and Lynch syndrome is needed or necessary. That doesn't stop experts sitting around and trying to come up with guidelines. And so all the guidelines I'm going to talk about aren't based on New England Journal of Medicine papers. They're not based on Nature or Science papers, but they're not quite fake news. They're a bunch of recommendations made by people sitting in a room trying to figure out what should we tell patients. So they're guidelines based on expert opinion. And when you look at the levels of evidence, meaning how reliable is evidence, expert opinion is sort of looked at as pretty low level evidence. So the NCCN guidelines are the guidelines I used when I was studying for my exams and surgery. They say that selected families with a family history of gastric cancer or those of Asian descent should undergo screening OGD, and that if you're going to decide to do that, you should do a gastroscopy or upper endoscopy every 3 to 5 years, starting at age 30 to 35, and that if you find H. pylori, that you should eradicate it. Okay? Again, another separate task force from the US made guidelines in 2014 that said at around the same time, 30 to 35, that you should get an OGD one time, and that you should follow up with certain patients 2 to 3 years based on individual patient factors. So they don't tell us what those are, but we can infer what they mean by that list that I talked about: family history, certain genes, male gender, family history, H. pylori, etc., etc. The Mallorca group in Europe, also very recently, expert opinion, no evidence, said that there's no evidence for surveillance, but that maybe we should screen people for H. pylori, and if they have H. pylori, that we should eradicate it with 2 weeks of therapy, and that in high incidence countries, so some areas of Europe, there's more H. pylori and more stomach cancer, that you could do surveillance, but we shouldn't just offer it, that this is something that we should study and research, and it shouldn't just be done ad hoc. And the European Society of Medical Oncology released the guidelines in 2013, and in 2014, the American Society of Clinical Oncology endorsed these, so they didn't make them up new ones. They said, we agree with what these guys say in principle, said that we should test for H. pylori and eradicate it in patients with who carry a Lynch mutation. And that doesn't mean that you need an OGD. So one of the things that is lost in a lot of this is H. pylori can be tested in ways that don't require an OGD. And then in cases of, in areas of the world where there's high incidence of stomach cancer, some experts, so when you see words like this, some experts, that means these guys really argued about it in the room and couldn't decide, and so they said some experts, these guys, said that we recommend OGD every 1 to 3 years, which is a lot of scopes, and really there is no evidence to support this. In South Korea and Japan, where they have high risk of stomach cancer, the screening starts at 45 or 50, and happens every 2 to 3 years. And that's in countries that have risks that are twice that of the Lynch risk in Western Europe and North America, and much higher than the baseline risk in Canada. So it's kind of confusing, and this is where I feel for you guys, because these are 4 very reputable New York Times level news sources, and they're telling you various different things, and probably very different than the information that you get from some of us. And so the question is, what should we do? So one thing I don't think that we talk about enough is intestinal metaplasia and atrophic gastritis as risk factors for developing stomach cancer in the future. And the other thing is, we don't know if we watch patients with Lynch in their stomach, whether or not we actually will be able to find stomach cancers before they become aggressive. So the difference between colon cancer and stomach cancer is in colon cancer, we have evidence. We know that if you watch people's colons, that there is less cancer and less death. And probably the shorter interval is probably better. In stomach cancer, we don't have that evidence in South Korea or Japan, and we don't have that evidence in Lynch syndrome. And what we don't know is that even if you catch a small stomach cancer, whether or not it'll make a difference. So, I am not an expert, I don't have that many letters after my name, but I think we need to have a conversation about this, because you will worry and you will ask during your colonoscopy, hey, why don't you just take a look at my stomach? And I know someone who had Lynch syndrome and stomach cancer. And it's a very, very reasonable worry. What I think should happen, and one thing I am willing to offer all you guys, is if you want to discuss how this goes about, that you, I'm happy to see you guys a referral, because I think it's very complicated. We need H. pylori eradication in Lynch syndrome carriers. I think that's a no-brainer. I think if you have intestinal metaplasia or atrophic gastritis, that you should be followed, Lynch syndrome or no Lynch syndrome. And there's not enough knowledge about those in the general public. There's not enough knowledge about that in the general medical public. So I think if you have an OGD and you find intestinal metaplasia or atrophic gastritis, that we should tailor some sort of surveillance based on your individual risk. So if you're an 80-year-old South Korean immigrant who had H. pylori and is a Lynch syndrome carrier, I mean, I think it's probably pretty reasonable to look at your stomach. You know, if you are 30 and had H. pylori testing and it was negative, there's, you know, MLH1, you're a female, there's no stomach cancer in your family, I don't think we should all be rushing to get gastroscopy. I mean, there's risk to these tests. It's patients with Lynch go through enough testing already, enough worries already. So I think we have to be very cognizant of that there are people who probably should be screened and surveyed, but it's not everyone. And I think we need to have a dialogue. And if you want to speak to your genetic counselors, I'm happy to see you guys in clinic and discuss your individual risks. Because I don't think we'll have an answer for this for a long time, because you know, in 10 years, the risk of stomach cancer and Lynch is not going to be 7 to 9%. It's probably going to be 4 to 6%, and this number is going to be a moving number. So, in summary, we have no evidence. But I think we should have a dialogue, and I invite you guys to ask questions at the end of this talk, and ask questions of me if you're so inclined. Thank you.